CardioSource World News has done several articles on the challenges related to managing the care of the approximately 30% of patients with atrial fibrillation who also have heart failure. In the November 2016 issue of JACC Heart Failure, Oral Anticoagulants in Patients with Atrial Fibrillation and Heart Failure, does the heart failure status influence efficacy and safety? And I should mention that this is a CME offering in that particular JACC Heart Failure. To talk about this paper, I am with Gianluigi Severese, who is MD and from the Karolinska Institute in Stockholm. So first off, why did you decide to do this comprehensive meta-analysis of the efficacy and safety of what we call NOACs?
Yeah. First of all, thank you very much for inviting. Heart failure is actually a global pandemic, and so actually the prevalence of atrial fibrillation in heart failure is around 40%, and heart failure is considered to be a major risk factor for thromboembolism in atrial fibrillation, and it's even included in CHA2DS2-VASc score. Actually, it's also considered to be a risk factor for reduced therapeutic range in patients with atrial fibrillation using warfarin. So actually the problem of oral anticoagulation in heart failure is quite important, and NOACs with their more predictable efficacy and more safe hemorrhagic profile seems to be an attractive choice in patients with atrial fibrillation and heart failure. However, there are no randomized clinical trials in this setting, but just subgroup analysis for the from the three big phase trial, but these are just subgroups analysis, and they have no enough statistical power to check the impact of NOACs therapy on less frequent events, as for example intracranial bleeding. Right. For this reason, we decided to plan this study, and we decided to design it as a meta-analysis.
Well, it gives you like 55,000 patients to analyze. So what did you find in this meta-analysis?
Yes, we pulled data from all the 4 phase 3 randomized clinical trial on NOACs, and we had 2 aims. The first one was to compare efficacy and safety outcomes in heart failure versus no heart failure patients with atrial fibrillation. And then we wanted to check if the NOACs effects and safety was different in heart failure versus no heart failure patients. So we first found that risk of stroke and systemic embolism and bleeding, major bleeding, was the same in patients with heart failure and patients without heart failure. And we also saw that the risk of intracranial and any bleeding was reduced in patients with heart failure, and but the risk of mortality was reduced in patients without heart failure. The fact that the risk of stroke and systemic embolism and the risk of major bleeding was the same in patients with and without heart failure looks a little bit strange, and this result that could seem quite counterintuitive, and in contrast with what we said earlier, can be justified by the inclusion criteria of NOACs trials. In fact, all patients in NOACs trials were using anticoagulants. This could have altered the comparison between heart failure and no heart failure patients in trials, and patients with heart failure in NOACs trial were actually younger, with less prevalence of hypertension, and so with lower blood pressure levels. So maybe this can justify the reduced risk of intracranial bleeding that we showed in heart failure. Actually, patients to be enrolled in NOAC trials had to have atrial fibrillation plus at least one other risk factor for thromboembolism, including heart failure. So maybe there is an inclusion bias in patients without heart failure, as major other risk factors for thromboembolism could obscure the impact of heart failure on bleeding and stroke efficacy in patients with heart failure. Then let's talk about NOACs. NOACs were demonstrated to significantly reduce the risk of stroke and systemic embolism and the risk of major bleeding and of intracranial bleeding and of any bleeding in patients with heart failure without any impact on mortality. In patients without heart failure, they reduce also stroke embolism risk of major and intracranial bleeding with an effect also on mortality. However, there is no difference in safety and efficacy of NOACs between patients with and without heart failure.
One of the points you make in the paper is that heart failure is associated with an increased likelihood of suboptimal time in therapeutic range in AF patients treated with warfarin.
Sure.
Why is that? I mean, it's mostly the complexity of the situation, correct?
Exactly, that's the problem. Actually, there are several studies checking this. As VARIA and in HF, they were demonstrating that comorbidities as heart failure, but also frailty or diabetes or COPD or CKD, they were all having an impact on therapeutic range in patients treated with warfarin. Actually, more comorbidities means more complex therapy, and more complex therapy means less compliance of patients in using the drugs. Actually, heart failure is also associated with high rates of hospitalization, and hospital admission for these patients means changing diet, changing lifestyle, and in this situation it's quite different to manage the warfarin therapy.
Exactly. So, because this is such a large analysis and you've managed to essentially go through all of the data that's available from these clinical trials, are these findings sufficient at this point to actually support the preferred use of NOACs in patients with heart failure, in your opinion?
This is a $1 million question, actually. We demonstrated that the effects of NOACs were very good in heart failure patients, and the safety was great. There was no difference in heart failure as compared with patients without heart failure. This means that I would warmly support the use of NOACs in heart failure patients. Then we can check in the future data from registries, checking what's happening in real life.
Well, this is a fine paper, and it is the CME offering for the November 2016 JACC Heart Failure. So please check out the paper, the accompanying commentary, and for CardioSource World News and CardioSource World News Interventions, I'm Rick McGuire.